further ado, we'd like to welcome Dr. Hannah Cox. Please introduce and tell us what you're going to talk.
So do you need me to share my slides? Okay, just give me 1 second.
And if you can't, then I have it ready for you.
I apologize. This is my first time. I'm very excited to be here, so please forgive a few little bugs. So my name is Dr. Hannah Cox. I am an Associate Laboratory Director at Prevention Genetics, which is an exact sciences company. And I'm hoping to talk to you about the genetics of breast cancer and the importance of family history and also getting genetic testing. So just before I start, because I work for a larger company, I have to give you a few disclosures. It is a sponsored presentation. As I mentioned, I'm an employee, but I'm also a shareholder. I'm going to focus some of the content today on one of our hereditary cancer tests, which is called RiskGuard. And I just want to make sure you're aware that I'm not providing any clinical diagnostic or treatment advice for any particular patient or situation. And then I'll just jump down to the end, which is more important to me, which is if you do want additional information on this test or on the products available at Prevention Genetics and also Exact Sciences, you can reach out and just check out this website. So with that, I'd like to get straight into it. And I want to kind of set the scene by talking about hereditary breast cancer in general. So about 70% of breast cancer is sporadic, about 15 to 20% is familial, which I'll talk about in a minute, and about 5 to 10% is hereditary. And when we're talking about hereditary breast cancer, it tends to have very specific features. So you'll see cancers on the same side of the family with multiple affected individuals. You'll see young ages of diagnosis, multiple primary or bilateral breast cancers in a single individual, triple negative status. There may be some very specific ancestries that are affected. And you also will see clustering with very specific types of cancer, particularly ovarian, pancreatic, prostate. And when I'm saying breast cancer, I also mean male breast cancer here. But sometimes in some individuals, there may actually not be a family history present. This may happen if it's traveling through the male lineage or if individuals are from smaller families or if individuals are adopted. Now, the next big slice that I'm really interested in with my work is familial breast cancer. And this is about 15 to 20% of all breast cancer cases. And what you tend to see is more individuals in a family that are affected than what you would expect by chance, but there's no single underlying genetic cause to it. And what you'll find in these cases is individuals tend to have an older age of diagnosis. Now, what I've talked about with the statistics, they're primarily driven by female breast cancer statistics, which is a little frustrating. But if we get down to male breast cancer statistics, it is pretty significant. So in 2021, 2,650 men in the US were diagnosed with male breast cancer. 530 men actually passed away from male breast cancer. It accounts for 1% or 1 in 100 of every cancer that is detected in men in the United States. It accounts for 1% of all breast cancers. And what's a very defining factor compared to female breast cancer is men tend to have a later age of onset, which is an average age of 68, but some individuals do get it at much younger ages. Now, the previous talk just talked about risk factors really nicely. I'm going to address that too. There are a lot of risk factors that increase your chance of male breast cancer in your lifetime. And this includes just the aging process, being overweight or obese, your alcohol consumption, and also dietary factors, your exposure to radiation, including across your chest area, your exposure to female hormones, such as increased levels of estrogen and androgen. This can happen due to hormone therapy, testicular injury, castration, and a number of other factors. And then the two ones that I really want to address today is that family history component and also that genetic component. But please see with the plus symbol, there are a lot of other risk factors that influence male breast cancer predisposition, and many of them we're still yet to define. So when we're talking about the genetics of male breast cancer, it can range anywhere from 4 to 40% of it being due to inherited genetic changes, which are also referred to as mutations. The biggest player, as was mentioned in the previous talk, is BRCA2. That's estimated to confer an up to 8% lifetime risk. Some studies say it's even as high as 22%. And then there are a number of other genes that also increase your risk of male breast cancer when you carry an inherited mutation. And that's BRCA1, CHEK2, PALB2, and several other genes. And then there's also genetic syndromes such as Klinefelter syndrome and Leigh-Fermani syndrome, which is caused by mutations in the TP53 gene that increase your risk. Now, in terms of family history, if you have one relative that's affected with breast cancer at a young age of diagnosis, you have a 2.5 times risk compared to the general population of developing male breast cancer. And we see that about 20% of all men with male breast cancer actually do have a first degree affected relative, which supports that risk. And then what's incredible is as the number of affected individuals in your family with cancer, including breast cancer, your risk can actually end up being 5-fold greater than the general population or even higher. Now, just to really get into the genetics of it, when I'm talking about genetics here, I'm talking about your germline, and that's your DNA profile in just about every cell of your body, and this is distinct from tumor testing. And when we're talking about germline, I'm also talking about doing the genetic testing of your germline. So we're looking at DNA that's derived from nucleated cells in your body. Each one of those contains your genome, which ends up having 2 strands of DNA, each with 3 billion units, or what we call base pairs. And it encodes about 20,000 genes. And each of those genes creates a biological product that works within the cell's machinery to help you function as an individual. What we find is with cancer genes, these proteins or gene products, actually a lot of them are involved in mechanisms like DNA damage repair. And so what the really important part is when you know your inherited cancer variant, it actually helps you inform your personalized care options, including prevention, early detection, and minimizing recurrence of additional cancers. And what I'm showing here is just to drive home that germline component is we've got a sperm cell here with the father's DNA carrying a mutation as an orange star that fertilizes the egg. And then those cells start dividing, and each one of those cells has 50% of its DNA from the mother, 50% of the DNA from the father. And then in this individual, they're also carrying that inherited germline variant. And you can see as that individual ages and grows, they may or may not pursue genetic testing depending on their personal and or family history. In this case, this individual did, and they got a positive result with a BRCA1 pathogenic variant. Knowing that status means that individual now can get personal risk estimates of their cancer recurrence, familial risk estimates, and they can also start personalizing their medical care and management through informed surveillance and also therapeutic and surgical options. So with that, I want to talk about the test that we have here at Prevention Genetics and Exact Sciences. We call it RiskGuard, our hereditary cancer test. It's a panel looking at 32 hereditary cancer genes that assess the 8 most common types of hereditary cancer, which I have listed down here on the bottom slide. All of these genes are actually clinically actionable, they're evidence-based, and there's a lot of professional and medical society guidelines around using these to manage patients with cancer. And by using this this number of genes, remember I said there was 20,000 genes in the human genome, having a really curated sets of genes actually minimizes the uncertainty for the patient. The other great thing about this test is we provide an individual report, which we give you individual and familial cancer risks and also give you potential care options that you can use to discuss with your healthcare provider for your future management. And just to really highlight that it does include genes that are associated with male breast cancer. In terms of how we generate these results and how we analyze the DNA, we extract that DNA from your cells. That's usually from a blood sample, from a cheek swab, or from a saliva specimen. We then run it on these wonderful machines called DNA sequencers. We analyze all that genetic information for those 32 genes, and then any genetic changes that we find, and I'm showing these here in the DNA sequence, orange, green, and red, we determine whether they're clinically actionable, which is pathogenic or likely pathogenic, are clinically benign, likely benign or benign, or whether they are uncertain, and then we generate a report for the patient. I'm going to go over this very, very quickly because I don't want to go too far over time and make sure I leave you some questions. But when you get a positive report, it usually means you have a clinically actionable pathogenic or likely pathogenic genetic variant. It's typically inherited from your family. In rare cases, it can be a new mutation that arose really early in embryonic development that we refer to as de novo. By having this positive result, you can actually manage known cancer risks according to these professional and medical society guidelines. And you can also really inform your family members through what we call cascade testing, which I'm going to address at the end of this presentation. One thing that is worth keeping in mind is because you have 8 common cancer types on here, sometimes you can get an unexpected result. You may have a family history of breast cancer, and then you may end up with a colorectal cancer pathogenic variant. So there can be some little curveballs in here. And then the other main results are negative and indeterminate, is where you'll have no genetic variants, or you'll have genetic variants with unclear or no clinical actionability. And in this case, we can't offer you any advice about your personalized risk factors. You just remain at the population risk. So the purpose of doing hereditary genetic testing in general, but also with this particular product, is for people with cancer. You're trying to explain that main driver of cancer. You're hoping to direct your treatment options, inform surgical decisions, and determine whether you potentially have risks of other cancers that you were not aware of that you need to start early screening and early prevention for. And then once again, it's all about that those family members and giving them that information as well. For people without cancer, that really helps you with really upping your screening and your medical managements for early detection and early prevention. And really as well to, once again, it's all about the family, including guiding family planning. So with that, I'm going to just give you an example of what this could do for a male breast cancer patient. I'm using a hypothetical patient here called David, who had male breast cancer. He went through testing and he was BRCA2 positive. Because of this result, he actually started prostate screening to make sure that we were on top of that. He also had the opportunity then to discuss the management of his male breast cancer and also risks of other cancers such as pancreatic cancer with his healthcare provider. He has a psychological benefit to actually knowing what the main driver of his cancer is. And then he has the ability to share these results with his family and make sure he really drives home that early prevention and early detection component. To give you an idea of what a family history could look like for this individual, I've highlighted David here in green. He's got this purple circle as a background. If we go up to his father's side of the family here, everybody is deceased, and we can see there's one maternal aunt that had breast cancer at a very, very young age, less than 50. So that's actually a big risk factor. His grandfather had cancer of an unknown diagnosis and died at age 70. His father had lung cancer. And then there's some other health related conditions on both sides of the family. If we go over to the mother side of the family, we have a maternal aunt that died at 40 from ovarian cancer. Now, it's worth considering that if we look at the risks that I've included down here for this BRCA2 gene, is you actually have increased risk of female breast cancer, male breast cancer, prostate cancer, ovarian cancer, and pancreatic cancer over your lifetime. So this case of ovarian cancer actually also fits in with having a BRCA2 positive finding. And then we have some other other individuals up here that died from early on from accidents or from other health conditions. So the kind of take-home message here is if you have one or more family members with breast cancer died at young ages or other cancers diagnosed at young ages, it's really important to look at to consider there's a genetic component. It's important to consider that BRCA2 mutation can be passed from males to males or passed down from males to females to males and females. Be aware of individuals in your family that died young before conditions may be evident, because it may actually mask hereditary conditions within your family. It's also really important to remember that many cancer genes are actually associated with multiple types of cancer. So if you have a male breast cancer diagnosis and you're talking to your relatives, don't just focus on breast cancer. Ask about other types of cancer, including ovarian, pancreatic, and also prostate cancer. And it is important to remember that when you're doing these genetic testing, it's all about lifetime risk. Having a positive result doesn't mean you're definitely going to develop cancer. It means you're at a significantly increased risk compared to individuals in the general population. So it's not a slam dunk in that sense. Now, in terms of informing other family members, and we refer to this as cascade testing, it's the process of testing through a family in a specific order to identify all the individuals who did not inherit that BRCA2 mutation in this case, or the cancer gene in this case. And what you're really looking for here is impactful early cancer detection and prevention. And once again, if we go back to this family, this individual, I've drawn them out here. They have children and grandchildren, nieces and nephews. They've got siblings and parents, and all these individuals around them in the family also have risks of carrying that genetic variant that increases their cancer risks as well. And just to finish off, because family history is such an important part of all types of cancers, but also male breast cancer, is please be aware that in 2004, the US Surgeon General actually declared November 24th as National Family Health History Day. And this occurs around Thanksgiving every year, where most families are together. And so this is the perfect opportunity to actually really dig in with your family members and start having very open conversations about your family's health history and asking about cancer diagnoses and the age and what type. And I'm just including a number of resources here that you can use to actually help you have those discussions with your family members. I also want to highlight that if you do have individuals with cancer diagnoses in your family, sometimes you can't always test them if it is a late onset diagnosis or if they don't have a positive outcome. And so one thing you can also consider doing is what we call DNA preservation or DNA banking. Whereas it may not be the perfect time to do genetic testing in the palliative care stages, but you can talk to your family member and get them to consider preserving their DNA, so you and other family members, when the time is right, can consider testing and determining whether this is genetic and possibly an inherited cancer within your family. And with that, I'll take any questions, and I'd like to just say thank you to everybody for inviting me, and thank you for listening.
Thank you so much, Dr. Hannah. We appreciate it. And we are open for questions. Anyone here?
She's got it.
Oh, okay. So yeah, you can drop the slideshow and we can open it up for questions there. There we go. Okay, Rick got it. Well, I can say that, Brett and I have had all the different testing, even the RNA, and we lucky were enough that it was not in our family genetics, but we do know that something exists because Brett has over 15. I have cousins on my side that all have breast cancer, but none of us run any type of mutation. So.
And I have to say, for me as a geneticist, so just to give you a bit of a background,
Sure.
since we're in the Q&A, is I did work for another company in 5.5 years doing cancer genetic testing. Here I have been for 4 years, and I do a range of different tests. And that includes, have you guys heard of exomes and genomes? I do those.
I don't know if we have. I don't think so.
So I told you that there's about 20,000 genes that are encoded in the human genome. So an exome actually looks at the coding component of all of those 20,000 genes, or cuts it down to a subset of the clinically actionable genes, which may be a couple of thousand. A genome looks at all the genetic material. And what I find absolutely amazing after being in this field for nearly 20 years is we're still discovering new associations and new genes. And for people like you, Peggy, and for Brett, I still hold out hope that at some point we're going to figure out those extra players that are contributing to breast cancer.
Well, yeah, and just know we're open to be tested anytime. So as long as insurance will pay for it, we want to get the answers, because it's not just us, it's the generations to come. They're the ones that need to know. They need, if we can catch it early, then there's hopefully no problem. So.
And just to touch on that before I take Bill's question, I really love the aspect of genetic testing that is all about early detection and early prevention. That's the best way to fight this, in my opinion.
I totally agree. Totally agree.
Bill, I would love to take your question.
Thank you. It's a real, pretty common one, I think, probably, and that is the RiskGuard test covered by insurance?
So we actually are trying to, in the process of getting Medicare coverage right now. We're actually expecting to get it by the end of November. And so we are expecting to have full Medicare coverage for this test.
Okay, if it doesn't come through, or you're not covered with Medicare, what?
Oh, we will be. I will say to you, we will be.
Okay, then what is the cost? My son works in Congress. I know how Congress works pretty well. You never know on these things, especially with what may be an upcoming change of hands there. But what is the cost of the test outside of insurance?
So I can't speak to that because I'm not in the accounts. They tend to keep us little science kids away from all of that stuff. But what I will say is, I know Exact Sciences and Prevention Genetics are always trying to ensure their tests are affordable and can be accessed by all individuals. And I know that's a very, very big part of our company's mission.
That's great.
And I can say they do that. We've had many of our men, they have a charitable side. They've always helped out. They've never denied anyone for the test.
That's great. I'm glad to hear that.
And I'm sorry I can't give you more information, but you're right.
I understand.
I will get on my soapbox. Once again, this is my personal opinion. It's not the opinion of the company. I really think genetic testing needs to be accessible for all individuals, regardless of their age and of their ancestry. And I've seen many studies as a geneticist over the past 20 years that have shown, how restrictive clinical genetic testing can be, and how hard access can be. And I think my generation and the clinical geneticists moving forward is, we really try to be advocates for that, and we really do want genetic testing to be accessible to everybody.
I think that's terrific, because the early days of it, 10 years ago when I got tested, there was one company that did the BRCA mutation testing.
Myriad.
Yeah. And they wouldn't share the technology with anyone, and the cost was $3,500. And it took 4 attempts by my doctors after I had had my first mastectomy and diagnosis to get my insurance company to approve it. And that was private insurance. And now I'm covered under Medicare. And
well, I can say we're doing everything we can to get Medicare coverage. I was a big part of that submission, and I'm planning to fight for it, because I want people to have access.
Thank you for that. That's terrific.
And we'll help in any way. We'll become.
I love it.
I love it. Behind you all the way.
I will remember that.
Dude.
And hopefully, the accessibility of tests of this nature and the importance of them becomes something that is a regular part of our physicians' toolbox in terms of treating us.
Yes.
What concerns me a lot is that the statistics that you showed in terms of the number of male breast cancer diagnoses each year, the number of deaths from it, and the percentage of a total breast cancer patients that men are, has not changed significantly in the last 8 or 9 years.
Correct. And that is worrisome.
Yeah. Okay.
And that's why I really also try to drive home with speaking to you, and I think sometimes it's a common misconception is males can transmit this to other males if they have a mutation. Males transmit this to females. You just said before, and Jessica, please know I saw that you have your hand up. I will get to you. You know, you have children, you have grandchildren, you have all these people surrounding you in the family, and it's the statistics all focus on that single individual, and that single individual has just so many people around them. And then when you start adding up all of that, it's a lot. It may be 1% as the individual, but it's a lot more when we look at the family unit.
Oh, totally.
Thank you very much.
Jessica, I'd love to take your question.
All right. Thank you. My husband just went through the genetic testing, and his testing came back positive for an ATM mutation. And I noticed in your presentation, and what our genetic counselor also told us, was that they won't test our children until they are over 18.
Correct.
Can you explain to me why that is, why we wouldn't want to equip our children to be prepared for a potential lifetime of getting early screenings and things like that?
So once again, this is my personal opinion, not the opinion of the company. My understanding is that they want because cancer is classified as an adult onset condition, and particularly the cancers I'm talking about, there are types of inherited pediatric cancer, but there's also these ones that are predominantly adult onset. It's very, very rare to have pediatric cases in these genes that we're testing. With the exception, there's 1 or 2 that are an exception, and with those, I'm sure your genetic counselor would talk to you. But what they're trying to do is more maintain autonomy and the right to choose for individuals. And so you don't want, when an individual goes to have genetic testing, you want them to have the autonomy and the independence to make that decision and know that it's the right decision for them, because your genome is a very, very private thing. And you can also, when you get that testing, find surprises that you don't want to know about, and it can be very unpleasant. And so a lot of this is actually about maintaining choice and maintaining autonomy. I can't say that word now. Autonomy, and also allowing your child at the age of 18, they can go in there and get it done. If they are really, really concerned about it, I'm sure you can follow up with your genetic counselor and have more discussions. But I think for that, you said ATM?
Yes.
I think for ATM, to my knowledge, there is actually very either no or little evidence to suggest that individuals will actually get cancer at less than 18 years of age.
I mean, I guess my biggest concern regarding it is the increased chance for ovarian cancer, and the fact that we do have a daughter who, and they don't even recommend pelvic exams until, somebody's sexually active and at 21 anymore. So, whereas I know that the largest risk for people to die of ovarian cancer is before that age. So, trying to balance that
so that may be with I may be wrong here, that may be with global statistics about ovarian cancer, but if you're looking at these particular genes, I think the age of onset is actually a lot higher. These genes also have what we call a lot of these adult onset cancer genes have what we refer to as incomplete or reduced penetrance, meaning the proportion of individuals with the variant that get cancer versus don't get cancer, and it is never 100%. And
Right.
for I know for ATM breast cancer risk, you have a 20 to 40% lifetime risk of getting breast cancer, and that's actually considered a moderate penetrance. And we say moderate penetrance because between 20 to 40% of individuals with a pathogenic ATM variant will get cancer. It's still high. It's higher than the population risk. And I know when you're going through it as a family, that is scary. And it's scary when you're talking about your kids. But I have to say those guidelines are from professional and medical societies about the 18 years of age. And it's all about the penetrance, the severity, the associated cancer risk, while balancing that autonomy and right to choose.
Thank you.
So I'm sorry.
No.
I'm
No,
sorry
I
I
was
can't
just
help you
trying
more with
to-
that.
I was just trying to understand, because I mean, they mentioned wanting the kids to be able to make an informed decision, and it's like, as their parents aren't, we're able to make an informed decision. And so thank you for explaining that to me. I appreciate it.
Yes. That's wonderful, Dr. Cox. That we want to invite you back after the first of the year to one of our fourth Thursdays, which is actually you come on and you talk more in detail, just like you have, and then we'll have more question and answers. Would you be willing to do that?
I would absolutely love to, Peggy. Thank you so much.
Wonderful. Then if the fourth Thursday in January works for you, we'll email each other and we'll get it all scheduled, because this is the information our families need to know and need to know what to do, what to check, and what's available.
Well, just before I leave, please contact me. I also have a brilliant genetic counselor that I partner with. I'm kind of the nerdy side and she's the clinical side.
Both
And
of you
I
then.
actually would like to have both of us, because
Absolutely.
I don't think I did that answer justice to Jessica. So Jessica, I'm sorry about that, but my colleague, Deborah Hartsfeld, would be able to give you a lot more information on it.
Let's plan
Thank
it
you.
then, okay? So the
Perfect.
fourth Thursday in January. So we'll get together and get it all set up. So wonderful. Thank you
Great.
so much.
Thank you again for having me. Really love what you're doing and I love the enthusiasm. Have a wonderful week.
You too. Thank you again.
All right.